Transthyretin cardiac amyloidosis. They are starting to have commercials on television about
There's
it.
a lot of commercials on TV.
That's right, Rena. They are just swamping the airs. And so let me find out. How many of you have had carpal tunnel? Okay, lots of hands go up. Okay. How many of you have had back pain? Yeah, okay. How about tingles in your fingers and toes? Okay. All right. So these may not just be unidentified flying things. They may be part of ATTR CM. So let's find out more about it. And
Indeed.
what I'm going to do is go over some of the basic things because I found it helped to understand this webinar to know a little bit more about it. So raise your hand if you've had a condition that was misdiagnosed. Could you, Gigi, could you tell us a little about yours?
Oh, sure. For me, I have been having issues with shortness of breath and just difficulty in moving and walking and stuff like that. And for several months, I had been told that I had actually heartburn. And what it was, I actually had found out that I had had a heart attack and that it went undiagnosed. And then I ended up later having to have 4 stents, I believe. And then after that, 5 months later, I ended up having to have open heart surgery. So it was something that,
What did
for
they
me,
do in the open heart surgery?
they went ahead. I think I had a double bypass.
Okay.
I had 90% blockage in my left anterior descending, and then I had
Go ahead and talk to.
I had a 90% blockage in my left anterior descending artery, and then I had a valve, I guess, that I was born with that never caused me any issues until I was 48 or 49, and it became a problem, and they had to correct it. It went one way, and they actually need to change it to go the other way.
Oh, wow.
So that was my condition.
Wow, that's quite an intense misdiagnosis. I'm glad you're with us. Let me tell you about this ATTR-CM, Transthyretin cardiac amyloidosis. It's a chronic disease of the heart that gets worse over time, and it makes it harder and harder for your heart to do its job, sometimes leading to congestive heart failure. Amyloidosis is an umbrella term for when certain proteins in your body change shape and then cause trouble. Normally, proteins do not shapeshift. But in amyloidosis, the problem-causing proteins misfold and clump together to form amyloid deposits that they call fibrils. Your body can't break down these fibrils, so they cling to the tissues of various organs and make it harder for the affected part of your body to function properly. So not all of them go to your heart. Some go to your brain, kidneys, nervous system, and more. But in your heart, the fibrils accumulate over time, causing harm. When such a buildup occurs, it leads to cardiomyopathy. Cardio is heart, myopathy is muscle. So it's a disease of the heart muscle. The more proteins build up, the stiffer the heart can get. And that makes it harder for your heart to relax properly. When it can't relax, it causes the blood to back up into your lungs, causing shortness of breath, and unchecked, this can lead to congestive heart failure. So, what are these symptoms that show up for amyloidosis? According to this article, when you are in the early stages of the condition, you're more likely to have symptoms that are fairly common and unrelated to your heart, like carpal tunnel. When these fibrils accumulate in your wrists, causing tingling, numbness, and weakness, back pain. The ATTR fibrils accumulate in your spine, which leads to spinal stenosis, in which the spaces in your spine narrow, and they cause pain, numbness, tingling, and weakness in your back and neck. Autonomic neuropathy, that was a new term for me. That's the parts of the nervous system that act behind the scenes and control things like your heart rate, your blood pressure, sexual desire, and sweating. So here are some of the symptoms, which I have had all of them. Lightheadedness, yes. Dizziness, yes. Fainting, yes. Shortness of breath, which they call dyspnea. Is that the right way to say it? Not sure. As fluids back up in your lungs, it becomes harder to breathe. Swelling in your feet, legs, and abdomen. Exercise intolerance, because you can't get the oxygenated blood you need, and so you're tired very, very early. Peripheral neuropathy, or tingles in your fingers and toes, which is also common with diabetes. And what's called a ruptured bicep tendon, which is very uncommon in healthy people. A complicating factor is that this ATTR CM does not always cause severe symptoms. Left untreated, most people diagnosed with ATTR CM after the disease is already causing symptoms that can no longer be ignored live less than 4 years. Those who have the disease but don't have symptoms generally die of unrelated causes. So what I'm going to do now is turn on this webinar that Mended Hearts found someone to talk to us about it. And they will show you with a great video, a little graphic of what it looks like in your body. But if you would like to have the article from healthcentral.com that I got the rest of the information from, please sign it at the bottom. So I'll send you an email copy. It's called Transthyretin, Cardiac Amyloidosis, Everything You Need to Know.
Good afternoon and welcome to the webinar. Today we'll be learning more about understanding and living with ATTR-CM. My name is Mandy Sankouler and I'm your Field Services and Communications Director. And I'm joined today by Dr. Abbas Ibrahim, who will be sharing with us more information about ATTR-CM, some of its symptoms, some of its treatments and therapies, and we're just going to learn more about a condition that's really quite underdiagnosed and misdiagnosed. And now to introduce Dr. Ibrahim. So he is a doctor who discovered that clinical practice was not for him, and he went to the pharmaceutical industry, where he really found he would have the greatest impact on patients. He began his career in medical communications and worked to launch and maintain brands across numerous diseases, both in the US and around the world. He joined Pfizer in 2018, working with the rheumatoid community for the next 4 years. In 2022, he joined Pfizer Rare Disease and joined the medical affairs team, where he served as the lead on many different teams, had the opportunity to actually work in artificial intelligence, which was really interesting. We'd like to thank Pfizer Rare Disease for bringing us this presentation today. We are grateful for the education that Dr. Abbas is going to be sharing. And we would also like to let you know that if you'd like to join Mended Hearts, Young Mended Hearts, or Mended Little Hearts, you can do so at mendedhearts.org. Memberships start at $0. So Dr. Ibrahim, if you would like to go ahead, I'm going to stop share.
I'd just like to thank everyone at Mended Hearts and thank everyone for joining today. It really means a lot to all of us at Pfizer to be able to speak to you and tell you a little bit about it, this disease called ATTR-CM that is unfortunately often underdiagnosed and often misdiagnosed as a cause for heart failure. So just to let you know that the information that I'm going to go through today is for general audiences and just for educational purposes. And again, it's not really intended to replace your discussions with your healthcare provider. So if you do have specific questions about a condition or a patient or a case, it really is more appropriate to have that conversation with your healthcare provider. And all decisions regarding patient care must be made with a healthcare provider, considering that each patient is different. So again, this program is being sponsored by Pfizer, but what are we going to talk about today? I'm going to talk to you a little bit about heart failure, a little bit about ATTR CM, how it affects the body, talk to you about hereditary versus wild type disease, the two ways that it could be diagnosed. And then when we go through diagnosis, we'll then end with key takeaways. And that'll end the medical portion of the program. So heart failure and ATTR CM. So nothing new for you, this audience, right? Heart disease is a variety of conditions that affect the heart, and it's the leading cause of death for most adults in the US. And when we talk about heart failure, a little bit less than 10% of heart disease deaths are due to heart failure. But what is heart failure? Heart failure doesn't mean that your heart has stopped beating. And again, I'm not telling you anything you don't know already, but it just means that your heart isn't pumping as well as it should. It could either be systolic heart failure or diastolic heart failure. When it comes to systolic heart failure, it comes to the problem with the pumping of the heart and getting that blood out to the body. When it comes to the diastolic heart failure, it's the relaxation portion of that heartbeat and really being able to expand enough to get enough blood in. But this often happens after the heart's been weakened or damaged by other conditions. And again, as you all know, it starts slowly and tends to get gradually worse over time. When we think about the incidence of new cases of heart failure in people, it happens happens more commonly as you get older. And in patients who are 55 years of age or older, it's about 1 million people who were diagnosed with heart failure in 2014. Now we're going to talk about ATTR CM, which is often overlooked. It's really been underdiagnosed and misdiagnosed for many, many years. And what we're going to do is watch a quick video, and we'll move forward after that.
Transthyretin amyloid cardiomyopathy, or ATTR-CM for short, is a rare, life-threatening, under-recognized and underdiagnosed disease associated with heart failure. Here's how it can affect the heart. Imagine your body as a factory composed of many systems working together to maintain your health. Your liver is just one part of the system. And one of its jobs is producing transthyretin, or TTR, a transport protein that carries the hormone thyroxine and vitamin A, or retinol. When everything is going well, these four-part TTR complexes move throughout your bloodstream. But if you have ATTR-CM due to either age or an inherited genetic variant, the TTR complex becomes unstable and misfolds. Then they begin to join with other misfolded pieces of TTR. After a while, long strands are created and begin to build up throughout your body. This buildup causes the heart muscle to thicken and stiffen over time. Eventually leading to heart failure. Because of the impact ATTR-CM has on the heart, you may experience fatigue, shortness of breath, and swelling in the lower legs and feet. ATTR-CM can also cause unresolved, seemingly unrelated symptoms, which may actually be early indicators of ATTR-CM. If you're experiencing any of these unresolved signs and symptoms, talk to your cardiologist about ATTR-CM to get the answers you need.
Okay, so before I go on to the next slide, I just want to expand on that a little bit. So what you saw there was an explanation of how transthyretin can misfold and cause issues that end up looking like heart failure. But I want to go into a little bit more detail. So transthyretin is a protein that's found in the body. It's produced in a couple different parts, primarily by the liver, but it's called a tetramer. So that means there's 4 pieces. And I like to think about it as a 4-leaf clover, right? Now that 4-leaf clover when it's put together, is completely soluble in the blood and causes no issues. And as part of its normal life cycle, that four-leaf clover comes apart and comes back together, right? Now, when that's happening and everything is okay, no problem. But when you start to get that misfolding happen, what happens is those misfolded fibrils end up being insoluble in the blood, whereas transthyretin as a four-leaf clover is completely soluble. And so when you get these insoluble pieces, they find places within the body to lodge, like the heart, particularly in the ventricles of the heart or the lower chambers. And so what ends up happening is you end up getting these fibrils lodging within parts of the heart. And so you end up with your heart having these fibrils in between your myocardial cells. And so you get a larger heart, but it's not because you've got more muscle fiber there. It's because the amyloid is causing your heart to look bigger. And because of that, it's not able to relax as well. So ATTR CM is ultimately a cardiomyopathy that is associated with diastolic dysfunction. Okay. So why is it often missed, right? So there's a couple reasons, right? First of all, awareness of the condition is still pretty low. It was only until fairly recently, within the past 10 years, that we even had, treatments or even non-invasive ways to diagnose the disease. The symptoms that you saw carpal tunnel syndrome. You saw other things there that may be mistaken for more common causes of heart failure. And you're also talking about a patient population oftentimes that's older. And so there's comorbidities involved. And some of the symptoms that you see with ATTR CM can appear to be unrelated to heart failure. And so what were some of those signs and symptoms? So some of these are signs and symptoms of heart failure in general. So fatigue, shortness of breath, swelling in your lower legs, or peripheral edema are often things that you see. But other times it's things that don't necessarily look like heart failure. So biceps tendon rupture, particularly bilateral carpal tunnel syndrome, GI issues, pain and numbness in the lower legs. But think about this patient population when you're looking at an older individual. How many older individuals with heart failure have fatigue, have issues with their eyes, have a history of GI issues, whether they're, diarrhea or constipation, an irregular heartbeat, pain in your lower back or legs, some spinal stenosis, and again, even decreased or strange tingling in your feet. These are all symptoms that look like they're completely unrelated, but in actuality, they might be better accomplished and better addressed by one single disorder rather than think of these as completely unrelated. So we mentioned that there are some of these signs that you see that are heart related, right? So if you have a patient who has heart failure, particularly with preserved ejection fraction, where the heart is still pumping a relatively normal amount of blood, that's something that you often see. But you also may see that patients who are taking certain heart and blood pressure medications like beta blockers or ACE inhibitors or angiotensin receptor blockers, those could make the patient feel worse. There are also those non-heart related signs and symptoms like weight loss, lightheadedness when you stand up, and some of the other things that we saw in that infographic earlier. When it gets down to it, there are two different types of ATTR CM. There's wild type and there's hereditary. So when you're talking about wild type, that's associated with aging. We don't really know what's causing the transthyretin tetramer to not come back together and go back apart as well as it did when the patient was younger. It often affects Caucasian men over the age of 60, but we're finding more and more that women and men of other races can also be diagnosed. And it may be the most common form of ATTR CM. There's also a hereditary element to ATTR CM, and that's caused by a change or a mutation in one of your genes, and it's passed down from a relative. So I'm going to skip this and go here. Let's talk a little bit about genetics, right? We know that genes contain, instructions that determine our traits. So my eye color, my hair color, those are all determined by my genes, but they also carry instructions that influence the way the body functions, and it's made of DNA that's inherited, passed down from parent to child. But there's also gene mutations. So this is a permanent change in your DNA that makes up that gene. It could be inherited from a parent or occurred during a person's lifetime due to other factors. Most of the time, it doesn't have any impact on your health, but certain mutations can lead to conditions like hereditary ATTR CM. And when you're thinking about hereditary ATTR-CM, it's caused by a mutation in the transthyretin gene. And some of these mutations, like the V122I mutation, are inherited and passed down through the relatives. So when we talk about hereditary ATTR-CM, this is something that can affect both men and women, with symptoms typically beginning as early as 50 to 60 years old. Now, there's hundreds of different types, or over 100 different types of these mutations. And so you can imagine that based on the mutation that you have, that'll determine if you're going to get this at the earlier end or the later end. And it'll also determine if you're going to be more likely to be male or female with that particular mutation in ATTR-CM. As I mentioned, there are more than 120 known mutations that cause hereditary ATTR-CM. And in the US, the most common one of those is called the V122I mutation, where a valine and an isoleucine are substituted. And it's more likely to affect those of Black, African American, and Afro-Caribbean communities, particularly if they come from West Africa. Now let's talk a little bit more about hereditary ATTR-CM. So, I mentioned that the V122I mutation is found almost entirely in Black, African American, and Afro-Caribbean communities, and 3 to 4% of people in those communities are thought to have the V122I mutation, but not everyone gets it. There's something called incomplete penetrance that says that, not everyone with this mutation is going to end up with the disease, and we ultimately don't know what percent of people with that mutation are going to go on and develop symptoms of hereditary ATTR-CM. But we do know that people with the mutation are more likely to get hereditary ATTR-CM compared to those who don't have the mutation. So how do you go about diagnosing the disease? So, if your doctor is going to suspect this, there's typically a long process before you even get to the point where it is suspected. You might get, you might have one of these heart-related or non-heart related issues, and you could go through the cycle of, seeing specialists and going through the rigmarole and maybe being misdiagnosed or being undiagnosed. But when it's finally suspected, typically your doctor is going to say, hey, let's get you an EKG or an ECG, an electrocardiogram, which is going to measure the electrical activity of the heart. And they're going to look at that, and they're potentially going to look at an echocardiogram, and that's going to look at the structure and function of your heart. They may even do a cardiac MRI to take a look at the function in a little bit of different detail. Now, if some of those parameters come together and they start to look more and more like ATTR-CM and their suspicion is really there, then we're going to go through diagnostic testing. And diagnostic testing can either be invasive in the form of cardiac biopsy, where a piece of your heart is taken out and examined under a microscope, or a non-invasive route called nuclear scintigraphy, where you're injected with this radio tracer, and after a couple hours, you're imaged and you say, oh, this really does or does not look like ATTR-CM. So once you identify that a patient does have ATTR-CM, we do recommend genetic testing and counseling, because that helps confirm whether you have hereditary disease or if you have wild type disease. It determines whether your relatives might be at risk, because that mutation, as we talked about, could cause hereditary ATTR-CM, could be passed down. And it's usually pretty straightforward and used performing blood or saliva samples. Ultimately, if you or someone has heart failure and is experiencing unresolved symptoms, going to the doctors often and over and again, being admitted to the ER for exacerbations of your heart failure, it's important to talk to your doctor about your experience and recognize that ATTR-CM is a condition that gets worse over time. And so early diagnosis is really critical. So some key takeaways. We talked about the fact that new cases of heart failure in people 55 years of age or older in the US was about 1 million in 2014. We also talked about the fact that ATTR-CM is serious, it's underdiagnosed, and it can cause heart failure, but it's often overlooked because it could look like other conditions as well. And because ATTR-CM is a condition that gets worse over time, early diagnosis is really, really important. We also know that there are tests that your doctor can use to diagnose the disease, and ultimately anyone with heart failure and unresolved symptoms really should be talking to their doctor about those symptoms and how they could potentially get better care. And with that, I'm happy to take questions.
Thank you. That was a great presentation. So far, we've got one question. Eugene is just asking, when you say signs and symptoms, what are the differences there?
So a sign is something that you can see objectively. A symptom is something that you report. That's an easy way to think about it. So if I tell you that I have a history of bilateral carpal tunnel syndrome, that's a sign. If I tell you that I have fatigue, that's a symptom.
Thank you. I had a question. In your, you talked a lot about in your biography about the work you've done with doctors to help them identify ATTR CM. Can you just share with us some of the work that you are doing to get the word out about this?
Yeah. So I think the important thing to recognize here is that up until fairly recently, the only way you could treat ATTR CM was with a liver transplant to get rid of the factory that's creating this faulty transthyretin that's misfolding, or a heart transplant because you've got all this buildup and you need a new place to store, basically the heart that you have won't work anymore. So when you go back to 2016 or so, there was a non-invasive approach, the nuclear scintigraphy that I talked about, that allowed patients with heart failure to potentially get diagnosed without having to have a cardiac biopsy. So that was a really important milestone in patients being able to get diagnosed. And then the other component that I think is really important is really looking at, a patient's history, looking at their echocardiogram and their electrocardiogram and seeing if they match. One of the things we often do is we'll take a look at what we see on an echocardiogram and whether we see an enlarged heart, whether we see wall motion abnormalities in the ventricle, and comparing the size of the heart that we see to what we see on the EKG and the electrical activity. Because if we see a larger heart, if there's more muscle mass that's causing that enlarged heart, we would anticipate that on an EKG, you would have bigger waves on your EKG because there's more muscle that's creating that electrical activity. But in ATTR-CM, we often don't see that kind of commensurate increase in the amplitude of your QRS waves as we see in the thickness of your heart. And so when you start to see that, when you start to see a patient who's got these symptoms that don't quite match up, particularly when their history is really telling you that this is a patient who might be at risk, that's where, and oftentimes it's a patient who's been admitted multiple times for heart failure exacerbations with this history of both cardiac and non-cardiac symptoms, where you might want to evaluate that patient further.
It must be so frustrating for those patients who keep trying to figure out what's going on.
It is. Historically, these patients go through multiple specialists, including cardiologists. It may take 2 or 3 cardiologists before they get someone who knows about the disease and knows how to diagnose it as well. So really getting the word out to cardiologists and other providers is critical to making it a little bit simpler for patients to get to the diagnosis.
Yeah, thank you. Laura asks, are amyloid and calcium deposits in the arteries related at all?
Not that we're aware of. So they're going to cause different types of issues, right? So the amyloid is going to lodge in between cells of the heart muscle, right, between the myocardial cells, whereas the calcium deposits are in the blood vessels. So they're happening in different areas of your heart. And so we don't know that, we have no information that suggests that they're going to have similar impact.
Okay. You talked about how it can be identified, but are there treatments out there that will help, get their ejection fraction back up a little, raise it a little bit, or other treatments out there?
So complex answer to that. I think what I can say is that there are treatments out there that have been approved. There are also treatments that are in development. And what we have currently are treatments that are focused on making that tetramer, that 4-leaf clover, stay together a little bit better so it doesn't misfold, right? There are other products in development. There's even gene therapies that are being considered as well. But really, in terms of products that are on the market right now that are approved for ATTR CM, the cardiomyopathy associated with transthyretin amyloidosis, it's really currently limited to the stabilizer approach.
Okay. This is a specific question, but I think we can make it more generalized for the audience. The anonymous attendee says, I have an abnormal ECG because of an ICD pacemaker. Can ATTR-CM still be suspected in such a case? So generally speaking, in that case, could that be a possibility?
Yeah, so generally speaking, it could be something to consider, because one of the things that may happen in a patient with ATTR-CM is that the amyloid doesn't necessarily, there's no Google Maps that tells you where to go if you're a misfolded amyloid protein. So it could go in between the myocardial fibers, but it could also lodge within the, around the valves themselves. So one of the things that may happen is, you may have a patient with aortic stenosis, and ultimately part of the cause of that aortic stenosis is amyloid. Similarly, if there's some sort of an irregular heartbeat, atrial fibrillation is something that we often see in patients with cardiac amyloidosis as well. And so, again, without getting into specifics, having a pacemaker doesn't mean that you don't have ATTR-CM. It also doesn't mean that you do have ATTR-CM. So if you're having unresolved symptoms, ultimately, talk to your doctor, let them know that you heard about this disease and you're wondering if it might apply to you.
Okay, thanks. Laura again says she was concerned she had an eye disorder, carpal tunnel, swelling in the legs, and a nuclear scintigraph. I'm sorry, I don't know how to pronounce that, which showed no whiteness in the heart area. So what's that whiteness that she might be referring to?
So when we talk about nuclear scintigraphy, we don't know how it works or why it works. We just know that it helps us diagnose the disease. So what you look at is you will have your EKG and your echo, and then if those are suggestive, then you'll go in for nuclear scintigraphy. And what they'll look at is the opacity or that whiteness of your heart versus your ribs, right? Because the nuclear tracers that we use are called bone avid radio tracers. So they come up on the bone, and we really see, is there more of that in the heart than we're seeing in the bone? And when we're seeing similar or more uptake in the heart than we're seeing in the bone, that's considered more likely to be ATTR-CM. And so if you're seeing no whiteness in the heart, that pretty much rules out ATTR-CM, because it's got a really high sensitivity and specificity for the disease.
Thank you. Dolores has sent these questions in through email. Her spouse was recently diagnosed with ATTR-CM. I know you can't talk about his case, obviously, but can you what's the expected progression after a diagnosis generally for many patients?
So historically, without treatment, you would have, mortality was typically between 3 and 5 years. And again, it depends on whether you have wild type disease, whether you have hereditary disease. If you have hereditary disease, which variant do you have? Which hereditary mutation do you have? A lot of that plays a role, right? It also is going to vary based on how old you are and how early this was caught. If this was caught later, then the life expectancy is presumed to be shorter. But if it was caught at an early stage, you've got more runway. And then again, it also depends on whether you're treated. And so there's a lot to potentially tease into. And again, it would get into, what was the staging of your heart failure? What's your ejection fraction? What are your other issues? What are your treatments for it? And so without knowing those and without getting into those specifics, I wouldn't be able to tell you. But I will say, Dolores, I know it might seem like a horrible thing to get this diagnosis, but now your husband knows what's been causing these issues. So I want to thank him for being a warrior and for being really empowered enough to continue asking the question of what's wrong and how can I address it.
And the good news is she said he hasn't experienced symptoms yet. So that's a positive. She does ask about him being a carrier with few or no symptoms. Would you suggest that because he's been diagnosed, the family get some genetic testing done?
So I think the first step is for her spouse to get tested. And so if it is a hereditary element, then you can go down the line of seeing, okay, which potential parents, brothers, sisters, children might be affected as well.
Okay, thank you. I see some things in the chat, but that was all with Dolores. So Dolores, thank you for sharing that. I think that's all for the questions now. Is there anything you wanted to add, Dr. Ibrahim?
No, I just wanted to thank everyone for being on the call and thanking you for listening to me. And with that, that will be the end of the medical portion of today's presentation. So thank you again.
Any questions or things you'd like to know more about?
Well, I mean, I would just say that just learning about it recently myself, it's a fairly new thing. It's, it's really unclear what approach or what attitude you should take if in fact you have it. I mean, I guess with everything, I always try to feel that the overall trying to improve your general health and create a lifestyle that's healthy helps almost anything, or it can help sustain you where you are, without getting worse a lot of times. And that, I mean, that's almost what I hear here, is that there's not too much. I mean, I guess there are different forms of heart failure, right? And that's how I first heard this defined, it's a form of heart failure, but it doesn't sound like it's exactly that. It's symptoms indicating some type of heart failure,
It's why your heart is failing. It's because it's getting all clogged.
Well, okay, yeah.
Not in the blood vessels, but in the muscle. All of these things that are slowing it down. Up to the screen.
The symptoms that were described with heart failure, my mother had those. And although she may not have had the ATTR CM, which probably shortened the life of people much more severely, she was able to soldier through them to a ripe old age of 100. So just because you have heart failure doesn't mean you can't endure that and extend your life if you're vigilant about how you can be able to do that. So.
Okay, I think I'll close the meeting, the Zoom part, and we'll eat up all the food you didn't get.
It's a good presentation.
Bye-bye.